This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Okay, welcome everybody to another episode of PHM from Pittsburgh. I'm still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. And for those of you who are regulars, welcome back. We are a continuing medical education podcast started in 2016. We're at our 10-year anniversary. I've been saying it all year. I can't believe we got this far. So we're very excited about this. We're doing a lot this year. And one of the things we're doing is addressing this issue with vaccine preventable illnesses. This is one of our 2 series we're doing this year. Now, right off the bat, you have to know I could not do this alone. If you're a fan of the show at all, I do almost nothing alone. We were fortunate enough to partner with here at Children's Hospital of Pittsburgh, our Pediatric Infectious Disease Division. They have given us their time and expertise to help us walk through this very difficult topic. And today we're hitting 3 big ones. Before I do that, I forgot to tell you where we're from. So I'm at UPMC Children's Hospital of Pittsburgh at the Paul C. Gaffney Division of Pediatric Hospital of Medicine. This is where we've been coming from. Now, for these episodes, we've been having 2 expert guests. We're super fortunate to do that. And today is no exception. I can now say both of these guests are friends of the podcast. I've been on before. One name and voice you'll recognize from the COVID era being on like every other week. And the other one was just on last time. So let's introduce them and get them started. We'll start with, in no particular order, Dr. Marian Michaels. Dr. Michaels is a professor of pediatrics at the University of Pittsburgh School of Medicine. Her pediatric infectious disease training was at Great Ormond Street Hospital for Sick Children in London and at the Children's Hospital of Pittsburgh. She's faculty at UPMC Children's Hospital of Pittsburgh since October of 1992 in the Division of Infectious Diseases. She has worked extensively with infections in children, both in the clinical realm and in research, with much of her work dedicated to the epidemiology of infections, prevention of infections through vaccination, and infections in immunocompromised hosts. She is the PI for a CDC contract performing surveillance of children with acute respiratory infections or acute gastroenteritis to better understand outbreaks and determine how well our vaccines are working. Our second expert guest, we're going to welcome back to the show Dr. Megan Culler Freeman. You may remember Dr. Freeman a lot, which is an assistant professor and pediatric infectious disease specialist at the University of Pittsburgh here at UPMC Children's Hospital of Pittsburgh. She's an MD, PhD grad of the Vanderbilt Medical Scientist Training Program. She's an award-winning clinician educator and virologist specializing in viral pathogenesis. Her lab is pioneering new insights into acute flaccid myelitis, utilizing advanced human tissue models to understand how enterovirus D68 impacts the pediatric brain and spinal cord. Today, we're applying our expertise in neurotropic viruses to a deep dive in polio virus vaccine and its implications for modern pediatric practice. And remember, there's free CME credit through the University of Pittsburgh. Now, today we're covering polio, mumps, and rubella. So we're going to hit all 3 of those. Today's a big day. It's our only day we're doing 3 of them. So we brought in our experts for that. So doctors Megan Culler Freeman and Marian Michaels, thanks for joining us.
Thank you.
Thanks so much for having us.
All right. Now, as this is a CME podcast, we have to do our disclosures right off the bat. I will go first. Megan, I'll kick it out to you, and then Marian will kick it out to you. So I have nothing to disclose.
I also have nothing to disclose.
And I do have some funding from Merck, but not related to immunizations.
All right. Thank you for that. Let's start. We're going to start with mumps, and we'll hit that. So please take us back. Microbiology 101, first year of med school. We're in class. Tell us about mumps.
Yeah. So mumps is a virus, and it's an RNA virus that is in the family Paramyxoviridae. So really the same family that has parainfluenza. And as such, it's one of the respiratory viruses and spreads through respiratory tract secretions and saliva.
That was wonderful. Thank you, Marian. It was a nice refresher. Now, can you tell us, one of the things we really want to know about with these series is some of the epidemiologic data, specifically, how much do we see now? And then how much did we see before the vaccine?
Yeah, I'm going to start it the other way, if that's okay with you. I'm going to talk about what we used to see. Its name was epidemic parotitis. And just as that name sounds, We would see it in epidemic surges that would happen about every 2 to 5 years. And when they would happen, we'd have about 150,000 cases a year in the United States. It peaked in the winter and spring months of January through going even up to May, and was usually in young school-age children. With vaccines, that went down substantially. And by the year 2000, we had as few as 300 cases reported. So 150,000 down to 300. Pretty darn good for our vaccines. But then we had some outbreaks happening. So in 2006 and then 2016, 17, and even in a little after that, 2019, we had cases going from 3,000 to 6,000 during those years. So a huge amount less than when we were seeing 150,000 cases a year, but still seeing more than we liked, and the virus was clearly around. The epidemiology changed as well, that instead of it being that young school age group, we were seeing it in colleges, we were seeing it in the military, we were seeing it, oh my God, we saw it in the sports team. And Megan, I can't remember if you were here then or not, but in 2014, you might remember, or Tony, you might remember, that our dear beloved Penguins came to visit. I mean, the sports team rather than our little animals, but our little birds, but the Penguins came to visit Children's. Of course, everybody loved to see them. And then the next day, spread across the newspaper in Pittsburgh was that they had come down with mumps. So it was a big woo-hoo-hoo here. And luckily, we got away without having problems, really because our kids were vaccinated. So we really lucked out. I don't know if you guys remember that or not.
One of my favorite slides on an immunizations talk that I give is a picture of Sidney Crosby doing a news briefing with unilateral parotitis.
Oh my God. Right. That's yeah.
This is what I've been seeing throughout all these talks is the sharp drop in incidence after the vaccination. I mean, you go from 150,000 cases to 300, which is 0.2%. So it's a significant decline. And we had those little blips in 2016, 17, 19, but it's a huge drop.
I think this is one of the things to highlight for viruses that only circulate within humans. So because for mumps, humans are the only natural host and there is no contribution of viral spread or propagation in animal species, we're able to control these really impressively well with vaccination.
And even in the times when we have 3,000 cases, really, we're still talking about a 98% reduction with immunizations being the factor there.
Now, the reason we're doing these episodes is so physicians, clinicians, healthcare professionals who are out in the community or at the hospital setting, when they have parents, et cetera, because we're seeing more and more vaccine hesitancy, asking questions, our hope is to give them the information so they can delicately and gently help people understand how important these vaccines are. But we're going to see patients who haven't been vaccinated. That just seems to be the way things are going. If we happen to see somebody who's not vaccinated with mumps, what should we look for in the presentation?
Yeah. So the name epidemic parotitis is really helpful because it reminds us what mumps usually presented. And that was with swelling of one or more of the salivary glands. And most often it is the parotids, but it can be any of those salivary glands that swell up and really cause tenderness. 30% of boys who have mumps and were not vaccinated are going to develop orchitis. Now, most of the time it's unilateral, but it can be bilateral and it can be very painful. And with that, they also have a high risk of sterility. So that's not how they're going to present, but presenting with orchitis is something to remember. And that can happen even after the salivary glands begin to go down. So it is something to be on the lookout for, particularly in those unvaccinated patients. About a fifth of unvaccinated patients were asymptomatic, even in the days when we had no vaccine. So if it's spreading in the community, we want to just keep that in the back of our mind that people who don't have symptoms may still be harboring the virus and can transmit it to others. It also was the most common cause of viral meningitis. So if you did a spinal tap on someone that had mumps, 50% of them were going to have a CSF pleocytosis. Now, luckily, most of the time, the pleocytosis is mild, and accordingly, they don't have severe symptoms with the nuchal rigidity and everything that we think of with bacterial meningitis. But still, this was a big cause of meningitis just because of the sheer number, the sheer volume of people that would have mumps. And getting infected at an older age, if you're not vaccinated, you're more likely to have symptoms. So the risk of meningitis, the risk of encephalitis, the risk of having other inflammatory disease such as pancreatitis or transverse myelitis is higher in the older person who gets mumps who is not vaccinated. So I think all of those things are important to keep in the back of our mind. And really, that inflammation can be any of the organs. What am I forgetting, Megan? I think the heart, you can have myocarditis. You can have the kidneys affected, so you can have glomerulonephritis. So really, any of the organs can end up having problems, particularly in the unvaccinated person. But most common, it's going to be the salivary glands, and then for the males, it's going to be the orchitis, which is the biggest problem that we see.
About 30% orchitis in males who are unvaccinated. That struck me as high. That's a big number.
That is a big number. That's why we want those boys to be vaccinated.
Yeah.
And girls. Girls could actually get arthritis too. Not as common, but that is possible for a female to also end up with sterility problems.
So, Marian, if there's an outbreak in the community or exposure like our beloved penguins exposure, what's your incubation period you're thinking about for this virus?
Yeah, that's a great question. The incubation is 12 to 25 days after exposure. So really, once you're a month out, you're probably scot-free. But keep in the back of your mind, if you're not vaccinated, you possibly could have been infected, and you can infect someone else through your secretions.
Okay. All right. So then one of the things people are going to ask is morbidity, mortality, even sequelae if they're there, even years later, when they ask, why do we have to get this vaccine? What's the big deal? Now we can say sterility in 30% of boys, which could be a big deal to some people. But what do you say about morbidity and mortality here?
Yeah, well, I think that actually is a big deal. You tell a parent that their boy could have particularly the father, I'm going to say, but you tell them that their son could have their testicles shrivel up and atrophy. I think that's a big deal. That really has immense consequences for that young person, not during the time when they're young, but when they grow up and they choose to have a family and find out that they're not able to. So I do think that that is something that we really should take seriously, and that is a big problem. Encephalitis is obviously another big concern in my mind, because while it's rare with mumps and happens about 1 in 6,000 cases, when it happens, that can have intense consequences neurologically and for the development later on. And of course, having that much meningitis, even though it's mild in most cases, is not mild in every case and can lead to sensorineural hearing loss. So those are the types of things that I really worry about with mumps and the consequences of mumps.
Now, the one thing I was wondering, Marian, what about if somebody has symptoms? What do you recommend for isolation, or how long can you still see this virus shedding?
Yeah, usually we tell people to stay isolated for 5 days after the onset of parotid swelling. Now, keep in the back of the mind, they actually were shedding and were infectious prior to the time that they became symptomatic. So they probably had several days of shedding and infectivity before that, but you don't know. So at that point in time where we know they're swelling, we want them isolated for 5 days. If someone does a PCR test and tries to isolate, you can actually isolate the virus 7 to 9 days after the swelling, and you can even find the virus in semen and in urine up to 14 days after the time that they had swelling of the salivary glands. But
Wow.
that we don't think is major points of time of infectivity. So the period that we want for isolation is 5 days after the time that we see the swelling.
Now, treatment, if someone gets infected who is not vaccinated, most viruses treatment is supportive care. Is mumps any different?
Mumps is not any different. That's exactly what we still do is supportive care. So if you're having a lot of symptoms from that parotid swelling, having them suck on lemon drops to help decrease that and to decrease the pain is actually the best thing. But really, it's just supportive care, plenty of rest, keeping them hydrated, acetaminophen for fevers if that's occurring and for pain. We don't have any magic bullets, and so you just have to ride it out.
Now, if we have a situation where there's an outbreak and there's a number of people who were vaccinated, but because there's an outbreak, they get mumps. What happens to someone if you're vaccinated but get this virus?
Yeah, just like our dear Sidney Crosby.
Just like I did. Cosby.
So we don't know precisely how many people are going to be asymptomatic but still get the infection when they've been vaccinated. There's probably higher than what we would see with the unvaccinated population. But the people that have symptoms, it's much less severe. Their risk of orchitis way reduced, and the symptoms when they have it is just not as dangerous as it would be if they were unvaccinated. So when we said that 30% of males who are unvaccinated and get mumps are going to have orchitis, that goes way down to about 6%. So not zero, but really so much less risk than what we had in the unvaccinated person. And also the risk of sterility is decreased as well.
All right. Well, that is everything we had for mumps. We are going to keep on trucking along. We're going to go right to our next infectious organism, and we're going to talk about our friend rubella. So again, take us back, Micro 101. Let's go the same way.
All right. So I was going to stick with talking about rubella as well, and then let my dear friend Megan take over with polio and the encephalitis issues. So rubella, again, is a RNA virus. It's a positive sense single-stranded virus. It's RNA. And there we go with our 101.
Micro 101. Okay, epidemiologic data. You wanted to start with how much we used to see prior to the vaccine versus how much we see now.
Yeah. So before the era that we had rubella vaccine, the virus would come in cycles, again, similar to mumps, but this time the cycles would be around 6 to 9 years that we would see it really surge up. We'd have about 50,000 cases of rubella in children annually. But when we would have those surges in cases, we would have over 10 million. I mean,
Oh, wow.
unbelievable numbers, so that the schools would just be rampant with it. And then congenital rubella, which we're going to get into talking about later when we get to symptoms, most years it'd be around 150 cases. But during the periods where you'd have these huge surges, like in 1964, 1965, so taking us back before we had the advent of vaccination, there were 20,000 cases of congenital rubella. I mean, unbelievable numbers, and really,
That's huge.
you think of the recent years when we had the Zika outbreak that was happening in South America and how just horrendous that was. Now take that number for being every 9 years, every 6 years into America, with 20,000 of those babies being born every year. Really a big fear for parents starting their families.
Those numbers are huge, Marian. So what happened post vaccination? I'm expecting very good things.
Oh my God, you are right. We have wonderful outcomes from rubella vaccination, so that it's estimated that we have had less than 10 reported cases of rubella in the years since 2012. I mean,
Wow.
that is amazing. And most years, incidence of congenital rubella is zero. 0 cases in the United States. Occasionally, there'll be 1 or 2, particularly imported from other countries. But in general, there are 0 cases of congenital rubella, and that is all due to the vaccine, 100%.
That 10 million number, it stuck with me because in the years before the vaccine, we went over this on one of the other episodes for this vaccine series. Daycares weren't as popular as they are now. Now daycares are used way more heavily in the U.S. So it would just be a huge breeding ground for rubella to spread if it were to come back anywhere near what it used to be.
Yes, I completely agree. Completely agree.
Well, if it does come back, what should we expect in presentation?
Yeah. So, this disease in people who are already born, so not talking about the congenital infection, we'll get to that later, but it's actually pretty mild. Now, it had the name, sometimes people will call it German measles. It also is called 3-day measles. I had to look up, believe it or not, why it was called German measles because I could not remember. But it was that in the 19th century, the German doctors were the ones who gave such a wonderful description of it that it then received the name of German measles. And the reason they described it was to say this infection, this rash disease is different from measles and different from scarlet fever. So that is how it got the name German measles. Now, if you think of it as that name, you're also going to remember that similar to measles, it does start with an erythematous macular papular rash that starts at the face and works its way down the body and usually generalizes within the first 24 hours. There can be some lymph nodes. There can even be some mild cough and headache, coryza, and even some conjunctivitis, just like you see with good old-fashioned rubeola with measles, but much, much more mild, and the rash lasts 3 days. So I love the name 3-day measles because it makes you remember that mild time in that short time frame. So about 20 to 25% of people who have this infection before the time of vaccine would be asymptomatic. And the cases of encephalitis that we know were not uncommon with regular measles, 1 in 1,000 cases, the type of encephalitis with rubella is much less. So 1 in about 6,000. There could sometimes be thrombocytopenia, so petechiae, then about 1 in 3,000. The other thing to know is that if women got it when they were older, so the teenage girls, the young adult women, sometimes they'll also get a polyarthralgia or even present with polyarthritis. So that's just something to keep in the back of the mind if you have unvaccinated population that's presenting with polyarthritis. Keep this in the back of your mind that it could be rubella infection. At any rate, these cases, for the most part, are very mild. So that people are like, well, what the heck? Why do we even need a vaccine against this virus? But the really big reason for that is the horrendous and dire complications that can happen when a pregnant woman gets the infection, particularly in the first trimester, and can lead to congenital rubella syndrome. And, it takes me back to my childhood because, of course, I was born before the vaccines were available. And my parents had finally gotten us to an age where they could send the 3 children, my 2 brothers and myself, off to camp and had planned a party because they were sans children and could have a big party. And what did I have happen while I was at camp? I developed rubella. Now, I wasn't that sick, but I got sent home from school. Got sent home from camp and sort of ruined their planned party a little bit. But, they put me to bed, whatever.
Sure.
And there was a young woman who was there who I remember vividly to this day because she was just beautiful. And she had recently gotten married and they hadn't started to work on having a family, but she had never had rubella. So when she heard that I had rubella, she decided she better get it before she tried to get pregnant. And she came and hugged and kissed me like nothing. And I was not a huggy child. So that was really something that I will never forget about rubella. I hope she got it.
Oh, God.
But that was what women did, right? Like this was the time period where there was no vaccine. And you wanted to have rubella before you ever started a family because there was such intense fear of getting rubella during pregnancy. The babies were just like what we think about with torch syndrome. They could be born small for gestational age, so that intrauterine growth retardation, the microcephaly, the hepatosplenomegaly, thrombocytopenia, and petechiae. This was the most common reason that babies would be born with that blueberry muffin look. So those spots of extrahematic hematopoiesis and petechiae that we would see in these babies. And then you would think congenital rubella over the other causes of congenital disease if they had specific abnormalities of the eye. So particularly cataracts and glaucoma and cardiac disease with PDAs or peripheral pulmonary artery stenosis. And there was a high risk of hearing loss, but of course that's also found with the other causes of congenital infection. So this was a big cause of problems in our newborns and a big fear for congenital infection if the woman had acquired rubella during the early part of pregnancy.
Well, now this is remarkable. I mean, I haven't reviewed congenital rubella syndrome because I'm not an ID specialist, and we haven't really seen it since med school. And then, is there any? I think I remember reading pneumonitis or bone disease can also occur. Is that right?
Yeah, yeah. Thank you for bringing that up. It can. So pneumonitis and bone disease can be found with this infection. Those are usually self-limited and get better. But the central nervous system diseases that can occur in the congenitally infected infant are the ones that are going to maintain the big problems for later development. So having extreme developmental delay, sensorineural hearing loss, and behavioral problems. Do you know this virus is one of the few infections that is proven to cause autism?
Mm,
It's sort of ironic, right? This is
yeah.
ironic that here RFK is claiming the vaccines caused autism when in fact the virus is the one that causes autism, and we can prevent that with the vaccine. So really a situation that we don't want to have to see.
Well, now you kind of described all the long-term morbidity, mortality, and then sequelae, even for our congenital patients born with it. And then we've talked about how prevalent it was. And then treatment, is there anything, or is this also supportive care because it's a virus?
Ah, just supportive care.
Just
We
supportive.
have no treatment for this. So when you get it, you got it. And that was, I think, the biggest problem, particularly for the pregnant woman. And, I was thinking about it, Tony, when you were talking about daycare and how things can spread. A lot of teachers are young women of reproductive age. And if you had rubella in the schools, you were going to get infected if you had not already been immune and had it previously, or in today's world, been vaccinated. So it is just critical that we ensure that everyone is vaccinated, and why we take this also so seriously. So even in today's world, when you're pregnant, you get a rubella serologic test on every single pregnant woman with every pregnancy.
So is it fair to say if you're vaccinated and there's an outbreak, even if you're a young person who's trying to get pregnant, who can get pregnant, you're covered?
Yes, you are covered. Even a single vaccine has 97% protection. I'm not going to say there's ever anything that's 100%. So, but if you're exposed and you have been vaccinated, and particularly if we know your serologic status is positive, you don't have to worry. You do not have to worry. So that's really something that's just so critical and really information that has to be out there for our families to know that being vaccinated is to protect you during pregnancy and to protect other women during pregnancy. And when the vaccine originally came out and countries were making their decision on how they were going to vaccinate and what the vaccine strategy was going to be, it was always fascinating to me because I think some countries that weren't as economically advantaged as we are in the United States, rather than vaccinating all children, said, you know what? If it's the women that need to be protected, let's just vaccinate the girls. So they would vaccinate the girls during adolescent period of time. And so that meant half the population wasn't protected at all. And
Yeah.
that kept the virus in circulation way too much so that it turned out not to be an ideal strategy. So it was a little bit of saving pennies, but not saving the big bucks. And the countries have now gone to the strategies that we have in the United States of vaccinating everyone to protect the women during pregnancy.
Yeah. Penny wise and pound foolish.
Yes, penny wise and pound foolish.
Marian, what about this? What we're hearing on social media, this concept of the rubella vaccine getting created using aborted fetuses, and parents may ask about that. Do we have any information on that?
Yeah, I'm really glad you brought that up because it is something that people are going to ask about. And I think that it's important for them to know the facts. So I think let's talk about that so that we have the facts so that we can help with that. So I think I mentioned earlier 1963 through 1965 when it was one of those huge surges where they were having 20,000 cases a year. Now, if you remember back to those days, which actually the two of you may not have even been born during those days, I'm sorry, but abortion was not legal in the United States back in that period, but exceptions were made for times where the woman's life was in danger or when the fetus was going to be severely affected by some kind of horrible disease, that there could be exceptions to being able to have a legal therapeutic abortion. And accordingly, during those time periods when there was such an enormous surge, there were about 5,000 legal abortions that occurred. Now, I should put that into perspective. There are about 6,000 spontaneous abortions that occurred because of that rubella outbreak every year as well, and another 2,000 neonates who died shortly after birth because they had been infected in utero. So from those, really horrendous decisions that these women had to make for themselves during a planned pregnancy, some of these fetuses that were severely damaged were able to be studied by the scientists who were trying so hard to come up with a way to develop a vaccine that could prevent the disease altogether. And one of those physicians was actually one of my mentors during residency, Dr. Stanley Plotkin. And really, he took this to heart that he needed to do something to help these families and to help these children. And he took the virus that he was able to isolate from the lung of one of these severely damaged fetuses to make the vaccine that we use today across the world to prevent rubella. So yes, there was the virus from an aborted fetus that was used. Now, furthermore, it was grown on a Wistar cell line that was a human diploid cell line that had come also from an aborted fetus because that was able to replicate and to be a continued cell line really for decades later. I think that was from the early 1960s, if I'm correct. I don't know if Megan, you're the scientist and the virologist of the group, if you remember correctly. But that's where that story comes from. And those vaccines, which have been able to use and avert hundreds of thousands of congenital infections of children who would be severely impacted and die often from these diseases, now can have healthy lives because of this vaccine. This was not without controversy, even back in the 1960s, as you might imagine. And the religious groups took it very seriously and really looked at it in great detail. And I think no more greater detail than probably the Vatican. And Pope Benedict, or I guess at that point in time, he was probably a cardinal still, they were tasked with looking at this and were able to conclude that since the fetus was not aborted for the purpose of making the vaccine, because the cell lines were not developed because of an abortion that was done to make those cell lines, and because there was no further abortion to keep maintaining the vaccine, and likewise, there's no aborted tissue in any form or fashion in these vaccines, that it was ethical to continue to use the vaccine, and that vaccine was so life-saving and was able to prevent abortions in so many cases that it was morally justified. And actually, every major religion has pronounced the importance of vaccines and put that forward. So thank you so much for asking about that, because I think that comes up, and we just want to forget about it, but it comes up and we need to be able to answer it.
Can I pop in about cell lines just for a second?
Oh, yeah.
Fascinating history. One of the things that I think is difficult to understand, because we talk so frequently these days about growing viruses in labs, is that in the 60s, this was incredibly hard to do. And the reason for this is viruses have a particular tropism for the cells that they will not replicate in every single type of cell. We see this in the human body, right? Not all viruses cause disease in every part of the body, and that's because certain viruses prefer or only have the receptors to be able to replicate in certain cell types. The technology for making cell lines in the 1960s was more limited than it is now, so we didn't have that many cell lines. The WI38 cell line that Marian mentions probably worked for rubella because it was from fetal lung tissue, and we know that that is a place that rubella can replicate. So compared to some of the other things that were available at the time, which were, cells from monkeys or cells from cervical cancer, if anybody's heard of Henrietta Lacks and her line, these were not ideal for growing rubella. So without that resource, scientists would not have been able to propagate rubella, and without propagating rubella, they would not have been able to make a vaccine. So even though we might have new tools in the year 2026, we were somewhat limited in the 60s for the virologic tools that were available.
I love a good historical go back to learn all this. And this is great because you're right. People are going to ask about all of this. And both of you gave us a really nice perspective to be able to understand both what was available at the time and what happened at the time. All right. We're gonna go long here. Let's keep on going. We're gonna hit our friend Polio. Megan, I think we're tagging you in for this one. So take us back, Microbiology 101. What do we need to know?
101, poliovirus is a picornavirus. Picorna stands for very small RNA, which is a commentary on both the size of the virion and the size of the genome. It is a very small RNA virus.
All right. Now, epidemiologic data prior to the vaccine and then post-vaccine.
So prior to the vaccine, polio was I would say, near ubiquitous infectious agent, and this paralyzed 10,000 children every single year. And of those children that were paralyzed, about 1 in 10 recovered. Of course, some had some degree of recovery, but this is the time that makes you think about, FDR having been a very famous example of a person that was paralyzed by polio, used a wheelchair for the rest of his life. Or we have these vivid images of children using iron lungs to help them with their breathing after having had paralysis from polio. So these were severe infections that could cause really long-lasting repercussions in any of the patients that ended up having those.
And now post-vaccine, Megan, I don't ever remember taking care of anybody with polio in my entire career. Am I just lucky?
You are a product of the time in which you have practiced. So the polio vaccine was a terrific success story. So this came to be, and as Pittsburghers, we love to talk about the inactivated polio vaccine, IPV, which is still used in the United States, that was invented at the University of Pittsburgh by Jonas Salk. So that became available in 1955. After that, oral polio virus vaccine came to be in 1961, the Sabin vaccine. And the United States used that oral polio virus vaccine for about 40 years until the year 2000. Part of the appeal of OPV was that it was easily delivered on things like sugar cubes. My parents used to tell me stories of just lining up in the hallway at school and everybody would get their polio sugar cube, and then they'd be good to go.
That was
Um,
me.
Marian's like, I was in that line.
That sounds delicious.
Incredible. And remarkably, because this vaccine was so effective, the combination of the two of them, the United States eliminated polio in 1979. So as long as I have been a physician, and before that, by a considerable margin, I have not encountered any cases of paralysis caused by polio virus. Now, there are some viruses that have presented similarly in present day. Some of the related family members enteroviruses, for which there are no effective vaccines in the United States. And recently, in an unvaccinated population, there was a single case of polio that was paralytic, isolated in a gentleman in New York.
Oh, wow. Wow. Yeah, it is 10,000 children a year, again, is not a small number that are paralyzed from the virus. Okay, so worst case scenario, we start to see more polio in the U.S. again after we've eliminated. What should we look for in terms of presentation?
So I would say that luckily, and much like the other viruses that we've talked about on the show today, most people don't have symptoms. So 72 out of 100, 72% will have asymptomatic presentation. If someone does have symptoms, 24% will have a mild symptom, something like sore throat, fever, fatigue, stomach pain, vomiting, constipation, nonspecific viral symptoms that we see with all sorts of viral syndromes. Where it starts to get a bit more severe or more concerning is the small percentage who will have aseptic meningitis. That's about 4%. So they might start with these mild symptoms and then 1 to 2 days later present with things like stiff neck or back pain, vomiting, headache. And this illness lasts for 2 to 10 days, but they usually make a full recovery, even though it can be unpleasant. The real thing that we are trying to prevent with the polio virus vaccine is paralytic polio. This one, interestingly, there are 3 types of polio, all of which are covered by the vaccine. Polio virus 1, 2, and 3 are the types, and their rates of paralysis are different depending on the type of virus that's circulating. So the one that causes paralysis the most frequently is type 1, and that will be one paralyzed patient for every 200 infections.
That seems like a big number because if you imagine if there's an outbreak in a city like Pittsburgh, I mean, we have what, 1.4, 1.2 million in Allegheny County. Even if a third of them are children, that's a lot of that's a fair number.
People were terrified of this virus when it circulated.
Yeah.
It tends to circulate in the summer and autumn, just like the other enteroviruses. And there are pictures of things like swimming pools being closed in neighborhoods, really shutting down any kind of community activity when polio was circulating in the community because parents were so scared of their kids contracting polio.
I can imagine. Okay, I interrupted you. Sorry, you were saying polio virus 1 out of 200.
1 out of 200. And 2 and 3 are more like 1 in 2,000 or 1 in 1,000. So significantly less paralysis causing than type 1.
All right. So besides, we talked about paralysis, any other morbidity, mortality, or sequelae even years later?
We talked a little bit about some of the long-term needs of a person who has paralysis, and all of this is dependent on the location of the paralysis, the extent of the paralysis, and how much recovery an individual person is able to make. One thing I do want to mention is something called post-polio syndrome. This is something that has been described where a survivor of poliomyelitis, paralytic polio, 15 to 40 years later, after they've recovered, will have symptoms that recur that are similar to their original presentation. And this is characterized mainly by muscle weakness and fatigue. And it's estimated how many people might have this, but somewhere between 25 to 40% of poliomyelitis survivors go on to have post-polio syndrome.
Is this a short-lived thing, or it stays with them the rest of their lives?
I think it can be persistent.
Yeah.
Wow.
Most
Wow.
of their lives, particularly in the older individuals who, might have just had a minor limp and then end up later with having really severe pain and problems with ambulation as they get older.
It's probably related to destruction of neurons. So neurons in humans, for the most part, once they are destroyed, they don't recover, which means that polio has a predilection for those neurons in these patients. So it causes damage in areas of the spinal cord that control the motor function. And as time goes on, they might have more inflammation in that area or perhaps less compensation in that area, which is why it tends to occur in the same kind of spots in the body that it had previously hit them.
That's remarkable. Now, we've talked about some of the data on what happened after the vaccines were passed, and we're on kind of a roll with treatment if you're not vaccinated and get polio. These are all viruses. It's been supportive care. Is polio the same?
Yes, supportive care.
Okay. And if we're vaccinated and we're in a country where polio is still prevalent and or it comes back in the U.S. and there's an outbreak, what happens to us?
So when poliovirus circulated after the vaccine had already been deployed, vaccinees might get infected, but they will not get disseminated disease. So they would be protected from paralysis, which is what we were trying to prevent.
So it gives them maybe the fever, et cetera, but nothing more serious. Good.
I'm just going to add in some of the things historically, well, not that long ago, but really from my era of training was when we used the oral polio vaccine in the United States, not the IPV. So, the IPV came first, then the oral polio was just so darn easy because it wasn't a shot. The kids didn't get sick from it. But, but then we switched back to the IPV or to the enhanced IPV that we use today. I think it's worth our listeners to know about the reason for that and what went through that thinking process. If it's okay for me to jump in at this point, the oral polio vaccine was almost a perfect vaccine. You took it in orally, and so it went into the GI tract just like the wild type polio, and it set up an IgA response. So you not only got protection of the central nervous system when it replicates and you developed your IgG, that you actually got an IgA response in the intestinal tract. So if you went traveling to an area where there was polio and you ingested it, you would not spread it because your body would stop it dead in its tracks even at that point in time. So it was practically perfect. And the practical part is the problem. When we had 20,000 cases of polio every year from wild type virus, we had 20,000 cases a year. If you ended up having some vaccine revert back to a wild type strain and cause polio from the vaccine, so vaccine associated paralytic polio, we knew would happen about 6 to 10 times each and every year. If you had 20,000 cases, those extra 6 to 10 were worth it in terms of being able to get everyone vaccinated. But when, as Megan said, we had no polio, 1979, no polio anymore in this country. Then having 6 to 10 cases a year that were caused by the vaccine were unacceptable, just unacceptable. And I remember when I was a fellow the first year, there was a child who ended up having severe combined immune deficiency syndrome.
Mm.
But we didn't test in those days. We didn't have the newborn screening that we do today. In those days, we tested for thyroid, we tested for maple syrup, urine disease, and PKU, but we didn't test for severe combined immune deficiency. So this baby got their oral polio and ended up coming and having polio. And it was the first and only child that I ever diagnosed with polio. And we then went on to diagnose them with severe combined immune deficiency syndrome. So having those cases really were just unacceptable. And that's when people went back and said, okay, now we really have to go back to the inactivated formalin-killed vaccines that we use today. In the beginning, we tried to do a combination, like you get your first dose a shot, and then you could do the oral polio vaccine, but that was just too complicated. And accordingly, we stopped using the oral polio vaccine altogether.
I think you bring up a terrifically great point, especially when you're talking about how the oral polio vaccine, which is attenuated, but not killed, not inactivated, in an immunocompromised patient in particular, would have the opportunity to replicate unchecked by the immune system. And this brings us back to something important about virology and how vaccines are made. So RNA viruses do not have error checking capabilities like your own cells do when they divide. So because of this and the fact that they have sort of leaky polymerases, they make mistakes with every cycle of replication. And this is often to their great advantage because they might evolve to adapt to a new host or to a new cell or a new tropism. Often it will lead to their detriment on a singular virion basis, but this is how mutations arise that then allow for revertant so that the attenuating sequence is no longer attenuating, but is back to paralytic polio. So my guess is that in that boy who was immunocompromised, the conditions were perfect from a virus perspective for mutations to arise and for that virus to revert. And because we have the inactivated polio vaccine, that's safe for people who are immunocompromised or not immunocompromised because that virus can't replicate, it can't change. And the case that I referenced of paralytic polio in New York a few years ago was caused by circulating type 2 derived from vaccine, probably imported from another country that uses OPV in a community that was not highly vaccinated.
Absolutely. This historical perspective is fantastic. Now, Megan, we get questions sometimes from people who are vaccine hesitant, such as, why not just let them get the virus? That's the natural way of vaccinating. I think I know your response, but I'd love to hear it from an expert.
I think the most succinct thing to say here when counseling your families is that there is no risk of an activated polio vaccine causing paralysis.
All right. So, Megan, can you talk to us about some of the issues you've heard when the polio vaccine and people who are against vaccine, anti-vax people?
Of course. So there are several things that I've heard brought up as concerns by families. I think one of the big ones is kind of the questioning of the necessity of the polio vaccine, especially given that it's not a virus that is currently circulating in the United States, although I will counter that, at least in some communities in the United States, we know because of wastewater sampling and because, the tip of the iceberg paralysis presentation that we heard about that happened a few years ago. If we know that was caused by type 2 polio, you remember that I told you that type 2 polio causes paralysis in 1 in 2,000 cases, which means that if we detected one, we know that virus was widespread in the community. So I think the vanishingly low risk is coming from a place of optimism, and we do currently have a low risk of circulation, but it depends on the community that you're in, and we are such a global society that these things can change at any time. The other thing that I hear sometimes is that the decline of polio was more related to increased sanitation and hygiene rather than by the vaccination itself. And the data just doesn't support that. So I think we can blame a lot of wonderful things on our improved hygiene and, potentially also the rise of some allergies. But I don't think that we should stop vaccinating against polio because it's a pretty important virus and we know that the vaccine is effective.
Interestingly, I've heard also people say to me frequently when they're against being vaccinated, the reason polio went away was we had better sanitation, just like you said. But in reality, this is one time where improved sanitation actually caused us trouble. Because in the days when there was polio circulating just endemically, this is a fecal oral transmission. And one of my mentors, Dr. Ellen Wald, used to say, the whole world is filled with the fine dusting of fecal material. And so, I mean, when you think about mothers saying, wash your hands, yes, that is absolutely right. Yes, don't forget to wash your hands before you eat and touch your nose and touch your eyes and everything. So fecal oral contamination is easy to have happen in the world. During that time period, when it was endemic and there was a lot of polio virus around, babies would acquire their first contact with polio when they were quite young and when they still had passive antibody from their mothers. So that period of time that they would get infected, they actually had protection against having it go into the central nervous system and having the development of paralysis or encephalitis, et cetera, et cetera. So having that dissemination, they would be able to halt it then, develop their own antibodies, and be protected. When we had improved sanitation, the babies were not acquiring it during that young period of time. And when they would acquire it, they no longer had maternal antibody. And accordingly, they could go on to have the paralytic polio that we started to see in the 1940s and in the early 1950s before the vaccine became available. So it was actually the improved sanitation that probably led to some of the epidemics that we had in that period of time.
That is fascinating. I had not heard that before.
Yeah, polio is an ancient disease. You can be found in some Egyptian art. So the
Oh,
fact that it really had a rise kind of mid-century is exactly like Marianne is talking about is because of improved sanitation.
this has been such a lovely historical episode. I've enjoyed this so much. So now we've gone through all three of our viruses, and normally this is where I give our guests an opportunity. If there's something we did not talk about that you wanted to make sure we brought up, now is a great time. Marian, I'll start with you, and then Megan, we'll let you go as well.
Yeah, so I think from the polio standpoint, as a Pittsburgh group, this is us. I mean, my God, when I hear someone speaking out against polio vaccine, it breaks my heart. We are the strength. This was the strength of our city, was that we worked together. The March of Dimes started to be able to raise funds to be able to have the polio vaccine. This is one of the biggest success stories I know. So please make sure you vaccinate your children. We don't want to go backwards. We don't want to go backwards.
I'll just add, Tony, thank you so much for doing this series. I feel like it is so timely and so important for pediatricians and practitioners to be able to feel comfortable and confident recognizing these diseases and, more importantly, continuing to do the hard work of counseling families who have questions.
Could not agree more.
It is my pleasure, and it is my pleasure to have you both on, two absolute experts in this area. Megan, Marian, thank you for joining us.
Thanks, Tony.
Thank you.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.